So next, please welcome Amber Johnstone. Brilliant. And she's going to present my ALS M&D patient mentioned wanting to die. Now what? A brief guide to conversation about death, dying, suicide screening for non-mental health. Thank you.
Thank you. Yeah, that's a lot, right? So I'm like everybody else, I'm so excited to be here. It's been so much fun the last couple of days just getting to meet everyone and chat, and I wouldn't have had the opportunity otherwise, so thank you to the Alliance for having me. I was trying to come up with kind of a clever title for a crappy conversation, and so this is what I came up with. And I was drawing on my experiences as a hospice social worker. And oftentimes, members of the multidisciplinary team that I worked with would come up to me and say, "Hey, Amber, our patient is talking a lot about death and dying, and I think they might be suicidal, and what do we do?" And so I would have a similar conversation with them as to what I'm going to have with you all today. And I found myself having this conversation a lot, and I still do. So that's why I thought it would be helpful to present this to you today. We're going to cover a lot, and it's in broad strokes, because we're going to talk about kind of three things. One, why as providers do we kind of make the leap from a conversation about death and dying with our patients to are they suicidal? And are they suicidal? What do we do with that? And if they're not suicidal and they're just asking for permission to discuss their own mortality, what do we do with that? So here we go. Spoiler alert, in case you want to zone out for the next 10 minutes, the kind of takeaway message from this conversation is that as providers, we need to be really keenly aware of our own biases and also our personally held beliefs and values surrounding death and dying. And I don't like to ask my clients to engage in an exercise that I myself wouldn't do. So here are some of my biases and the things that have impacted the conversation I'm going to have. So my experience and the norms and the beliefs that I hold around death and dying are very much that of the American perspective. And even though as a social worker I'm charged to be a culturally competent provider, I am as culturally competent as a white girl from Ohio who doesn't leave very often can be. So it's still a pretty narrowed worldview. And lastly, my professional life has been in the end-of-life care field, so that's all I've known. I experience death professionally on a daily basis, and so that repeated exposure and cumulative loss can kind of cause some desensitization to death and some bluntness around those conversations, and so I think it's important to kind of remember that. So before we get into the heavy stuff, I like to kind of have some fun stuff to start. And so these are some of the people that I care about in my life. As I mentioned, I'm a social worker in the state of Ohio in the United States, and I'm currently the care services manager at the ALS Association in Northern Ohio. But the pictures you can see my husband and my daughter Addison and my son Austin, and my furry coworker Winnie, who is not always a very considerate office mate as I work remotely, but I love her anyways. And then down at the right-hand corner for you guys, that's my work family. And so those are all my coworkers at the chapter, and they're actually having a watch party back in Ohio right now, so hi. So, okay, we'll get into the heavy stuff now. So here's some of the learning objectives for you. And my greatest hope is that you will take the last one and that you'll gain some confidence in having some conversations with your patients surrounding death and dying and suicide. So what is it about ALS that makes us as providers kind of make that jump of them having a conversation about death to are they suicidal? Well, unfortunately, as it stands right now, ALS is a fatal disease. We know that. You've probably heard some of the things that I've quoted up here from patients or something similar. You've probably heard this in your own practice. They say a lot of these things. And unfortunately, death is inevitable, and it is certainly right now inevitable in ALS. And so it is absolutely normal and appropriate for our patients to be having these conversations. What's important is what do we do with the information from there. So what is it about us? Why is it an us problem and not a them problem when it comes to these conversations? I think mostly it is fear. I think we're very uncomfortable and afraid to have these conversations. And imposter syndrome is huge. I absolutely suffer from imposter syndrome on a regular basis, and probably a lot of you do too. And if there's anyone in this room who doesn't, I want to talk with you, and I want your secrets, and I want to be you when I grow up, because it's tough. And so a little bit of audience participation, and it's very easy and quick, I promise. So how many of you here have experienced the death of a loved one? Can you, someone you care about, so can you raise your hand? Yeah. So for those of you playing at home, I'll describe the room. Everybody had their hand up, right? So keep that in mind as we go forward. That makes you qualified to talk about death and dying. And regardless of whether or not you have ALS, we all experience death and we will all die. And so you are very qualified to have these conversations, I promise. So talking about suicide, do people with ALS commit suicide? Well, unfortunately, yes. The studies kind of say that people with ALS, looking at them as opposed to people without ALS, they're probably 3 to 4 times more likely to complete suicide, which that's pretty scary, right? And it's especially true in areas where we don't have legal access to physician-assisted suicide. And kind of interestingly enough, when you're looking at, there was a study that looked at ALS and other life-limiting illnesses, and specifically cancer. And ALS seemed to have the highest risk for suicidality within the first year after diagnosis. But unlike other diseases, that risk did not decrease as the years went on with the disease. So it's important to talk about this, but it is also important to know that suicide is still a rare event, and we're talking about a rare disease. The research is limited as well, so if there are researchers out there that are interested, please look into this subject. But here's another little tidbit that I want you to kind of listen to and tuck it back in your mind, because we're going to come back to it later. I looked at a study that looked at the occurrence of clinically significant depression among people with ALS. And actually, the study found that it's not as clinically significant depression is not as common in ALS as we thought it was. It's not as prevalent. But what was reported was end-of-life concerns. So tuck that away for a moment. So what are the current best practices, and how do we decide, is someone suicidal, or are they just asking for permission to have a conversation about confronting their own mortality? Well, all comments need to be explored, because we have already established that people with ALS do in fact complete suicide sometimes. So we need to explore those conversations. We need to continue those. Don't be afraid to continue the conversation. Your patient probably doesn't have many other people to talk about this with, right? How many times do you hear a patient tell you, I can't say this in front of my spouse, or I can't say this in front of my child? You are a neutral person. They are asking you permission to have this conversation. And our colleague, Jamie, from the ALS Hope Foundation yesterday quoted Walt Whitman. And I thought that the quote really rang true with this conversation as well. So I'm not really quoting Walt today, I'm quoting Jamie, so thank you, Jamie. He said that we should approach these conversations with a sense of curiosity and not judgment. And I think that's really true for this too. So we're not persecuting any of our patients, right? There's no persecution here. We want to listen and to understand. And so if we listen with a sense of curiosity and non-judgmental concern, we can better understand and better support. Lean on your colleagues in these conversations. Know your own agency's policies. There's a very good chance that your agency has a policy on suicide risk and assessment. And so familiarize yourself with that, because that'll help you understand where the referrals should go next. And if your agency doesn't have such a policy, you should consider making one. And if you happen to be a licensed professional, you may want to check your governing board's policies. They may have some things to say about that as well. But here are the questions that you can ask if you're having a conversation with your patient and you think, oh crap, I think they might be suicidal. So there are two very directed questions that you need to ask. The first question is, have you been having thoughts about killing yourself? And are you having thoughts about killing yourself right now? So these questions are not a full assessment. These questions are to help you understand where the referral should go next. So if the answer to question 1 is yes, and the answer to question 2 is no, then that is what's considered a non-acute referral. We're maybe not talking about sending this person straight to the emergency room. We're talking about getting a further assessment completed. So you do want to take it seriously. This person is having suicidal ideation, but we want to get a trained mental health professional in to do a further assessment to decide what the safety risk really is and what the follow-up plan should be. So you should have that assessment done as quickly as possible, but it's not such an emergent situation that you're calling the social worker and saying, oh my God, they need to go to the emergency room. Now, if the answer to question 2 is yes, I am thinking about hurting myself right now, that is a medical emergency. They are probably a risk to themselves, possibly a risk to others. And so do not pass go, do not collect $200. Call the physician, call the medical team. We probably do need to get them to the emergency room for some evaluation. So that's kind of how that piece works. Now, if your patient looks at you like a crazy person and says, no, I am not suicidal, I have ALS, I am already dying, I don't need to do that to myself. What then? Because how many times have you, I'm sure that you all have had the experience where you ask your patient, so hi, how are you today? And they go, well, I'm dying. I'm really sorry. You're right. So they're asking permission to have that conversation, and what do? So let the patient set the tone, listen and validate. If you want to know the secret to being a social worker, listen and validate. That is what we do over and over and over again. You want to address their concerns very honestly, and again, know your referral process. So open the door or be the door. What the heck do you mean, Amber? What does that mean? So open the door or be the door. Open the door to the conversation. But if you find yourself in a position where you cannot today, we all have those days where we just cannot. I am not the person today. I am not the one. Do not ask me to have that conversation today. If you find yourself in that position, find the person who can be. Put your patient in front of the person who can have that conversation. So open the door or be the door. I don't know which one you are in that situation, but just try to make sure that support's available. But if you remember that study that I asked you to listen to and come back to later, it talked about ALS patients having concern about the end of their life, right? So here are some questions you can try. And my favorite one is, when you think about your death, what does that look like? Because we know that most, in the study at least, ALS patients are concerned about what the end of their life looks like. So have that conversation. Most commonly, they're probably saying that because they're afraid that their death is going to be uncomfortable. We've heard that earlier in the day, that people are afraid they're gonna suffocate to death. They're gonna have this horrible death. So have that conversation with them, and that conversation may then lead to, what does symptom management at the end of life look like for you? How do we make you comfortable? So I know that all of the people in this room and at home today, you know why this is important. You get it. But ultimately, these conversations will yield improved quality of life and improved outcomes. So in the States, and it sounds like probably in other areas as well, as the previous presentation stated, we're not great about getting our ALS patients into hospice as early as we can. And I think a huge barrier, at least in the States, is that hospice and ALS aren't so friendly together. There are just barriers to care. The measures that keep people comfortable in ALS tend to be considered aggressive in hospice, and so we don't always have access to that until it's really very late. But when we are able to do it and do it well and start those conversations early, more timely referrals happen. And we know that more timely referrals mean better symptom management. And there's a study that kind of blows my mind, that patients on hospice with good symptom management actually live longer than people who aren't on hospice. Now, it's days, it's not, it's not a huge amount, but still, isn't that crazy that somebody who's on hospice maybe will live longer than somebody who's not in a similar situation, and it's because their symptoms may be well managed. So the other thing is the money piece, and that there are improved outcomes and some cost savings to both the medical community, but also our families, because again, if you start these conversations early and they know what they want their death to look like and what that comfort means, maybe they're gonna stop some of those aggressive measures earlier that are really expensive. And maybe that means that that's going to save some really precious resources for them. So important stuff, right? So a couple crisis resources quickly I promised I would share. These are, I did find some international resources and also, of course, some of our stateside resources for suicide prevention and crisis management. There was recently a crisis lifeline, kind of rebranded, and they launched this 988. You can actually text or call 988 just like you would 911, and you'll be immediately connected to a crisis provider. So how wonderful is that? Here are my citations, and you can contact me at this information here. So thank you.
Amber, thank you so much for that presentation. I think it's so important. This is probably the first time that this topic has been discussed in a symposium such as this, and I think it's so important. And I think what you've done is given people a lot of confidence with simple tools to be able to help address and support their patients. Do we have any questions?
You're experts now. Great. Yeah.
During clinical trials now, they have to ask the suicide ideation question. Have you had any referrals coming out of that?
I have not personally so far, no, but I'm interested to see if that does happen and where those referrals will land. And I wonder how timely the follow-up care will happen, because right now there's a huge mental health crisis. We don't have enough providers, and people are waiting, even outside of the ALS realm, people are waiting way too long to get mental health care. So I'm wondering if that's going to be a challenge for us. So it's something to look at for sure. Thank you for asking.
I have a question right at the...
Yes. Hi.
Hi.
I'm just wondering, in the U.S., is it legal, the assisted dying or the euthanasia? Because I didn't get that from your presentation, so I'm not sure.
There are some states where it is legal. It varies from state to state. There aren't, somebody correct me if I'm wrong, I think there might be 13 states right now where it's legal. Okay, yeah. So I mean, it's tough, and it's different from state to state. So even in the states where it is legally, I will still say it is not readily accessible, and it is a very polarizing topic.
Do you offer that assistance of how they can access that?
So in Ohio, it is not legal. So I don't have the knowledge in Ohio. If we have had some patients say, hey, I'm interested in this, and we do try to find where the state, we give them the information about the states. And if somebody is very serious about it, we do try to connect with our sister chapters in that state to then try to get those resources. Thank you.
I think Sally has a question.
Actually, it's not a question, and I don't want to detract at all from your presentation because it's such an important topic and it was a lovely presentation.
Thank you.
I just want to make a plea about the word rare. I've heard it quite a number of times in the week, and I think certainly in the organisation I represent, we try not to use this word anymore because I think for people living with and affected by MND, it doesn't help us gain attention.
Yeah.
And so we tend to use 1 in 300 lifetime risk, which is actually one person in a cinema. Perhaps you have bigger cinemas than we do, but in the UK, that's one person in a cinema. That's not that rare. So it isn't directed at you at all, and it's just a plea for us to maybe think about whether the use of the word rare really serves our community.
Heard. Yeah, thank you for that.
Thank you for the presentation. I just had a comment and would love to have conversation about this. I think hospice, with the consolidation of hospices in the U.S., has been really challenging, and the movement towards for-profit, it's become even more difficult to get the services that we need. And then also the considerations of some of the Catholic hospitals and the challenges related to that. And, as we provide culturally competent care for people with different choices, that's just something we need to consider and have real conversations about. And I would love to talk more with folks.
Yeah, hospice is not a super friendly place for our ALS patients right now. So, I think it's a great conversation to have.
Oh, we have a question.
Hello. I just want to just kind of just echo what you were saying. And one of the first questions that I had when I joined onto the chapter was, is suicide, does that happen? And, you having this presentation, it kind of just gives those answers, and also just that reminder of, people, you're still living your life, you're still continuing on. And so you did really well. So
well, thank you
for sharing this.
Thank you. I appreciate that.
I think we've got another question coming in.
How do we prevent a patient with ALS from committing suicide at home? How do we have that conversation?
Gosh, I wish I had a great answer of how we could prevent it. I wish we had an answer of how we could prevent suicide with any situation. But it's okay to have the conversation. And I think there is a misconception that if we talk about suicide, we will increase the risk of suicide happening. And we know from research that that's not the case. So it's okay to talk about it, and it's okay to talk about it early on, because like I mentioned, the risk for suicidality is highest in the first year after diagnosis. So I think probably finding the person that you would be comfortable having that conversation with is the hardest part. So if we can charge our professional community to be more comfortable with these conversations, maybe our patients will have more access to those conversations.
There's a question over here.
Thank you, B.
Sorry, from the chat room, from Catherine, South Texas VA, and I absolutely agree with this. It is also important to explore how removal of treatment sometimes looks like suicide to others, and understanding nuance between the two.
Absolutely. Yeah, absolutely. People, I always hate to say people don't understand. But yeah, well, in our own professionals, I mean, I had experiences with our medical directors in hospice where somebody would say, oh, I just don't want to eat anymore. I'm going to stop having food put into my feeding tube. And the doctor said, oh, wait, we need a suicide assessment. Well, this person's dying anyways, and they've lost all control, and so control what little they can control. So yeah, thank you for that comment. I agree, and I think more education and awareness is needed.
We have a question in the middle.
Hi. This has just been from my experience in Arizona, is if we're at clinic and someone expresses suicidal ideation, the clinic team immediately sends them down to the emergency department.
Call the social worker.
Exactly.
Yeah, the panic.
Yes.
I know. Mm-hmm.
And then there's concerns, and I've raised these before, that they're not going to tell you next time. They're just going to do it. And it's been kind of an ongoing issue of we need to continue to build this rapport and trust and not immediately overreact. Do you have any suggestions to further advocate for our pals so that they're not bombarded by this? And it can be traumatizing, admission to the ER for suicidality when it's just suicidal ideation.
Right. Yeah. No, I think what you've said, and well done if you're having those conversations. But I think that's something that we as mental health professionals within the multidisciplinary team can do more of, is supporting our colleagues and helping them to understand and making sure they know we're not asking you to do this on your own. We're not asking you to do a full safety risk panel. We're asking you to ask some questions. So don't just stop at the, oh gosh, they're talking about dying. Are they going to hurt themselves? No, ask some more questions. Ask those detailed questions and then help them understand where the referral should go from there.
We've got time for one final question at the back.
Hey, Amber, way back here.
Hey.
Hey. Great presentation. Thank you. I was wondering, how do you support your staff with the instance, and maybe it's never even happened before, but if this comes up in a support group, and how to, it's harder to have that one-on-one conversation that you were sharing all the great tips about when you're in a group setting, and then the concern by other members in the group about that person's well-being. And do you have any tips for that real fast?
Yeah, there's a lot to unpack there. No, but I've had this happen. We try very hard to pre-screen our support group attendees before they've had their first meeting. And we unfortunately missed somebody who came in the group, and they were brand new to the group, and this was kind of an established group. And the first thing they said was, "Hi, my brother was diagnosed with ALS. I think he's going to kill himself." And I went, oh crap. Yes, it has happened. And so in those situations, I validate that is a very real concern. And my gosh, I'm so sorry you're dealing with that. And yes, suicide is a very real issue we should discuss. Is the group comfortable with that conversation today? And if they say yes, then great, let's have that talk. If anybody says no, or the group is mixed, I'll tell people, hey, it's okay if you want to log off today. If you have things you were hoping to talk about today and you're not comfortable now, please reach out to me. We'll talk about it. But it's also kind of managing the person who brought up that concern, kind of managing it that, hey, maybe this is a conversation that you and I need to have one-on-one, and maybe we need to talk about some referrals for some ongoing treatment. So I think there's a fine line. You've got to kind of manage the conversation so that we're not totally freaking everybody out and making them not want to sign back into a group. But it is a real concern, and it's probably something that somebody else in that group has a concern as well. So let's ask if we can have that conversation today.
Thank you. I think
Thank you so much. Thank you.
Thank you.